Hello, everybody. This is Dr. Blaskovich. He is a chiropractic doctor based in Vancouver, and he specializes in treatment, diagnosis of Atlantoaxial instability. He actually himself was a patient and is still dealing with his Atlantoaxial instability through non-surgical methods. So anybody who is looking for natural remedies, there's a lot to learn from him. Right. So today we are going to be mostly discussing ways in which this massively underdiagnosed condition by the name of Atlantoaxial instability is wreaking havoc on the lives of a lot of patients and their families, and the relationships that patients have with their family members. So today we're going to be talking about how we can reduce the amount of damage that it's causing. So like what patients can do, what doctors can do. So we'll start with that, and then we'll move on to talk more about diagnosis, since that is the first step in combating any illness. The first step is you make sure you know what it is. If you're getting misdiagnosed, if your doctor is telling you it's a concussion, it's a post-concussion, if it's post-concussion syndrome, like I was told, that's basically post-concussion syndrome means the doctor doesn't know what's going on. So it's basically a misfire, because if the doctor doesn't pinpoint what it is, they're going to say it's post-concussion syndrome. So we'll talk about diagnosis later on. So let's start with this. So Dr. Blaskovich, what do you think patients can do? Patients can do to on a wider scale. What can be done? Like for prevention, let's start with prevention. Let's start with prevention. I'm sorry about that. So let's start with prevention. So if somebody is suffering from Atlantoaxial instability, it's a pretty horrible condition. So what would be your suggestion as a doctor to make sure that it doesn't happen in the first place? So in terms of wearing a helmet while playing contact sports, avoiding contact sports, what's your take on?
Well, the fact that most patients who suffer these types of injuries, generally it's some kind of a momentum trauma. So if they're playing a contact sport, if they're in an automobile, if they slip and fall, if they get into a fight, or skiing, for example, horseback riding, getting bucked off a horse, all of these methods are basically injuries that are potentially going to happen. I guess avoidance of those activities is not the right answer, because you're going to limit people in living the quality of life that they want to live. But when you know there's a possibility, for example, if we just take the automobile collision as an example, because that is the most common reason or common method by which people sustain these injuries that end up haunting them for posterity, and oftentimes don't ever get diagnosed. There are ways to minimize the effects of these traumas, and assuming that the majority of patients or people get rear-ended, so hit from behind because somebody behind them is being negligent and is not paying attention accordingly, and they end up forcing a collision on the individual that becomes then the patient. I guess having the proper vehicle or the proper vehicle setup where they would be able to minimize the forces that would be transmitted specifically to their neck in an attempt to minimize how much shear trauma or shear forces get transmitted to their upper neck would be probably the most important thing. So obviously wearing a seatbelt is extremely important for saving one's life. So mitigating the setup in your vehicle is extremely important. For example, Volvo is kind of touted as the safest vehicle to be rear-ended in, simply because what they have is a headrest that goes up relatively high. It's built
Right.
in, and inside the actual backrest of these seats is what's called a whip system. And so what happens when you get rear-ended from behind, the first thing that happens is you're basically stationary in your vehicle and your vehicle gets pushed into you. And so your
Right.
back hits the backrest or gets forced into the backrest. So they have a plate inside the backrest that gets pushed backwards, but it's connected to bars that go into the headrest. So as it gets pushed backwards, these bars push the headrest closer to your head. So as your head's about to whip back,
Wow.
the headrest is brought closer to your head to basically absorb that impact. So as your head's about to go back, the headrest comes to your head, and then you slowly get absorbed backwards. So you don't actually have this traumatic whipping back, which is what
Right.
causes, first of all, the motion. But then as soon as your head hits the headrest, the rest of your spine keeps going. And then you have these shear effects. And that's usually what severs the ligaments or severely
Right.
stretches them beyond the point of them being able to heal. So these types of things, and then being, having the proper setup as far as if you don't have a Volvo, is making sure that your headrest. So if this is your head and this is the headrest, that the top of the headrest is at least level with the mid part of your head, but higher is better. I'm trying to get this. So
Right.
the
Right.
higher
Right.
is
Right.
better because, like I said, the first thing that happens when you get hit from behind is your torso, your back, mid back gets pushed into the backrest, which then elongates your body. It makes you taller. So then your head actually goes upward. So if your
Right.
headrest for starters, get this lined up properly, if your headrest for starters is lower than the midpoint of the back of your head, the moment you get elevated by getting hit from behind, now all of a sudden your headrest becomes a fulcrum and you can actually create more damage because of that. So if you have your
Right.
headrest relatively high, okay, and then and even higher a little bit, the moment that you get hit, you go up, but then your headrest is there to absorb. So that's called the top set of your headrest. And then there's a back set, which is how far back from your head it is when you're driving. So a lot of the newer cars or a lot of cars have headrests that have a up and down capability, but they also have the ability to tilt. And so if you can tilt it or slide just the headrest closer to your head, then you've got the proper top set plus the proper back set. So that if you do get hit, your head's closer to that headrest to recreate that absorption phenomenon that these Volvo car seats do automatically for you based on the fact that it's integrated into the backrest of the seat.
Right.
So that's probably the most important thing for reducing the level or the magnitude of these injuries, so that they can't be as severe as they are in a lot of cases. This still entails that a person consciously sits upright and closer to their headrest when they're driving, which might force them to take their backrest and bend it forward a little bit, so that they only in the beginning might feel unnatural because they're so used to reclining in their seats, which then puts
Right.
their head forward because they're trying to still stay upright to look forward. So then you've got the head and you've got the back set is all the way back here. So for them to do that, you have to either tilt this chair forward and then the headrest tilted forward, or they're going to have to lean back all the way, in which their case they're going to feel uncomfortable. They're going to have to tilt their head away from it to be able to look straight ahead of them. So those are the most important factors as far as in an automobile, reducing the severity, I guess, of these injuries.
Right.
Slip and falls you can't control. Being bucked off a horse you can't control. Athletics you can't control. And the reality of the matter is that helmets don't protect the neck. So a helmet will literally protect your skull from cracking.
Correct.
But oftentimes, as was the case with me, oftentimes the helmet is actually the thing that creates a bigger surface for more shear forces to occur. So if you picture a football player who has, the head this size and a helmet that then makes their head somewhat bigger in circumference, well, when their head hits the ground, so with the helmet hits the ground, and then the neck still has to continue going. And so because now they have got bigger head, there's more space for that neck to traverse and then shear downwards, also creating that same force that you get with the automobile with the poor back set, where you have more of that forceful trauma. And so, as much as the helmet protects your skull from cracking, which is a good thing to have, it oftentimes accentuates the trauma or the forces, the vector forces in the upper neck, because now there's a larger space for that movement to occur.
Right. Absolutely. That was a few pretty big points that you hit on. So in terms of driving, it's critical to first of all look for a some kind of vehicle with a safety mechanism, right?
Yeah,
If
so
that's
I'm not saying trade your car in for a Volvo, but
right,
most
right,
most cars have the capacity for that. Obviously the forward and back of the seat, that's all of
yeah,
them. But the vast majority that I've seen nowadays also have a headrest that is tiltable, or
right,
at least a portion of it is somehow adjustable so that it can get closer to your head.
right. So you move the backrest up, and then you make sure that the headrest is high enough so that when if there is a sudden rear end collision, that your head doesn't whip back
Yeah, so you
extremely.
basically the goal is to be cradled by your seat and the
Critical,
headrest.
right,
So the airbag is wonderful, but the airbag only protects you when you're going momentum forward and your car stops. So that
right,
then decompresses you or slows everything down, like almost like a matrix.
right,
Whereas when you get it from behind, because there's no airbag behind you, the only thing that can save you is the seat, basically. But if your mechanics or your positioning relative to the seat are not properly ergonomic, it's going to accentuate the forces of that impact.
right. What do you think of a lumbar support? For driving, there are some
Yeah,
attachments available. Do you think that will help in minimizing the impact of a rear end collision?
it will minimize, I think, the effects that it has on the lumbar spine, and
Right,
and potentially there'll be less straightening. So ultimately, I think the elevation of your body upon impact might be slightly reduced, but it
right.
does nothing to protect the neck from that shear force when you have the whipping.
Some sort of cushioning as well. I would expect if there's sudden push into your body, there would be a certain cushioning as well, especially at the lower. Right? You think that
It
would
would,
be
it would
right?
slightly, yep, it
Some
would.
slight amount of cushioning. All right. So that is that. In terms of helmets, we looked at. So in certain sports, helmets can increase the risk of a neck injury, but that doesn't mean we don't wear helmets when we're playing football.
No,
Obviously.
and I'm not
Yeah.
discouraging helmets. I'm just saying is that the
Right.
helmets, their number one benefit is preventing
Right.
skull fracture. So you'd rather have
Correct.
the helmet fracture than your skull to fracture. But as far as mitigating this pathology that we're talking about that eludes the vast majority of medicine, it actually promotes and accentuates the chances that you're going to have injury in that area because of a helmet.
Right. So basically, what that means is when you're wearing a helmet, for anybody who's playing sports, contact sports like football, even boxing, don't think you're invincible just because you have a helmet on. That's a takeaway, I think, right? It's
Right.
important to know that the helmet offers some protection going for the skull. You still have to be cautious, still have to be careful. So, right.
Correct.
In terms of falls, I would say for slips and falls, and for other activities that don't involve direct trauma to the head, I would say what I personally where I got the condition was snowboarding falls. So I was snowboarding, and I was a beginner. I made the mistake of going on the steeper hills. Just out of you get that feeling that the adrenaline kicked in. So there was some of that. But in terms of the major place where I went wrong was I didn't know how to fall correctly. That was a major issue. So
Yes.
uh, there, there are a lot of instructors that teach you how to fall. Even in the army, in the police, there's specific classes dedicated to how to fall. So I would say if you are into sports, get your hands on that kind of a class. Or if you cannot do that, at least take a few lessons. For example, I was snowboarding. I should have taken a few lessons. I just watched a few videos out of on YouTube, and I went to the hill. So that was a big mistake. You get professional coaching, guidance, and ask them, what's the correct method to fall. You tuck your elbow in, so on and so forth. If I had known, that I wouldn't have been in this place. But like that's a takeaway from my story. Make sure
That's a
you
you make a really good point, and I
right,
wasn't gonna really get into that because it's such a um, I guess that everything's available nowadays. It's just what I was going to suggest is actually some kind of martial arts training in which the first thing that comes to mind, is judo, because judo is nothing but holds and throws.
Right.
And so the biggest thing they teach in judo is how to fall, or how
Exactly.
to manage being thrown and how to land. And so, but yeah, so outside of getting some training, like you said, and it's nice to hear that there are courses available for that kind of stuff. But I think some martial arts training, and if everybody went out and did martial arts training, that'd be amazing.
Yeah.
To try to learn how to fall properly, because there is definitely, so that is absolutely something that can benefit any kind of situation that is an unsuspected sort of event, such as a slip and fall, or getting thrown off a horse, or wiping out snowboarding or skiing or what have you. Yeah, great
Right.
suggestion.
Right. Like when you see those parkour videos, there's a technique that they follow. They land on their hands first, then they absorb the impact with their arms, and then they don't go on their head directly. They always go on their shoulders. So like these, it's good to have that in your, especially if you're athletic, you're into sports. It's good to have that in your arsenal, right?
The
So
parkour guys are like human Volvos.
Yeah, yeah, right. Naturally, correct. They have the technology inbuilt, right? So this was in terms of prevention. So this is what we can do, right? So let's say now somebody wasn't aware of these things and they end up with a condition, which doesn't necessarily always result from physical trauma. Like from my speaking with other patients, some patients have developed Atlantoaxial instability as a result of exposure to mold, constant exposure to mold. I don't know if this is a common theme, but so in terms of that, I think that's also something where we can definitely touch on. So one of the patients I'm in touch with, she lives in Chicago. She developed Atlantoaxial instability as a result of the excessive amount of mold in a house. So that mold in the house led to mold building up in her body as well. So when she got the testing done, the mold testing done, it was way over the advised, the recommended limits. So in terms of mold, it destroys the whole body, the functioning of the body, and it's a pretty comprehensive effect that it has on the body. It's not only on the ligaments, it's on everything. So if you're experiencing something like a lot of fatigue, your brain's not clear, and abdominal discomfort and so on and so forth, it could be, and you haven't had any physical trauma, it could be an issue in the house. So it's good to have more testing done, and especially in northern USA and Canada, where there's the winters are long, so there's not a lot of sun, and it's easy for mold to get deposited in the air duct systems. So it's good to get that testing done, good to get that blood testing done. If there is a detection, what those patients have done is a complete detox, or right. So detox in terms of a diet change. So they've gone high raw vegan diets. They followed that for some periods of time to completely remove the build up. So that's something that any comments, doctor, on the mold and what can be done to do?
Absolutely. I mean, anything that's going to have a toxic effect on the body has the possibility to create inflammation all over the place in the body. And so it's not without reason to think that, severe toxicity levels like this, especially when the inflammatory markers within the body against those particular types of invasive species are so elevated, that there's no other explanation other than that's the cause of body-wide inflammation. And if that, for whatever reason, has an affinity for the atlantoaxial region, like for example, rheumatoid arthritis is a prime example of an erosive inflammatory autoimmune condition that has an affinity for the atlantoaxial ligaments, and that renders the chance that a rheumatoid patient will become unstable at C1, C2, causing atlantoaxial instability. And so, these mold species have shown to have the same sort of capacity to create this level of inflammation where, the body ends up attacking itself in certain parts. And so in both cases, ultimately detoxification will promote a benefit in the levels of symptoms and possibly even in not allowing instability to progress further.
Right. Absolutely. There is a story I would like to share. So, like one of the patients, she suffered with instability in her entire spine for around 30 years. So ever since she was around in her early 30s, she started suffering, and she suffered for 30 years, and she was in extreme pain, extreme suffering, and her condition was deteriorating. And recently is when she discovered that mode was responsible for her. Just a couple of years back, or I think a year ago, she discovered that mode was responsible for this after getting some testing in the house done and testing in her body done, the blood test, basic blood test. So that's when she went on this detox on a raw diet, and she experienced a lot of improvement to the point that she now is living a normal life. So she went from not being able to stand to now going on hikes, and so she's gotten a natural healing license. She's a natural, basically. She practices. She started practicing now to share her experience and what she's learned with others. So I'll make sure I leave a link to her Facebook or her email as well. So if anybody else experiences something, you can reach out to her. Her name is Heather. She's based in Arizona.
That's beautiful. That's such a wonderful story to hear.
Right. So now we were talking about, so this was prevention, right? Prevention. Now let's say a patient has developed this condition. What are the next steps? What can they do?
The best thing, if I were to just quickly jump to the punchline, would be to get functional imaging to determine whether or not they do have an unstable atlantoaxial joint or unstable atlantoaxial joints. I know that you've heard this enough times and been through it yourself. The sheer level of diagnostic activity around these cases can go from, unfortunately, not having any imaging done whatsoever and just medicating the entire time and trying this and then trying that and then trying that, to having a dozen or so different imaging studies, none of which actually test for the stability or the integrity of stability in the spine. So they're literally just looking at anatomy, hoping to find an abnormal looking brain or an abnormal looking spinal cord to be able to say, aha, there's our problem. And none of these testing modalities address functional assessment of what would be expected to be the normal amount of motion in the spine, and then determining, if there isn't a normal amount of motion at certain segments, how does that region of the spine, or how does the neurology in that region of the spine coordinate activity in the body? So if somebody, for example, had an issue sort of mid to lower neck, what would you expect if their spinal cord was being compressed in that region? Which limbs would it affect? Which organ systems potentially would it affect? Which function would it affect? And then conversely, if it was higher in their neck, closer to the skull, what would irritation of the neurology in that region would it look like if the patient presented with a problem in that region? And so that's basically the best way to diagnose is functionally determining where do they have too much movement, not where they don't have enough movement, but where do they have too much movement. And if they had too much movement in that region, assuming that excess movement somehow irritates the nervous system, what symptoms would you expect them to have based on that irritation of the neurology in that area where there's too much movement? And so if you can piece those things together and say, we found too much movement, we found it in this particular region, the nervous system that is housed within that particular region would have an effect on this, and this. And if you can tie those pieces together, you can say, even though we don't see damage on an MRI to that neurology, we can make the scientific inference that because there's excessive movement in that spot, that excessive movement could be putting pressure on the neurology in that region, yielding these symptoms that we're seeing on this patient. So kind of tying those pieces together to affirm that the likelihood that, and when people then get those answers, and to take it right to the very pinnacle of what people do after that, say they do get a fusion surgery, which then completely resolves their instability and their neurologic symptoms all go away, then you've just confirmed that too much movement caused irritation of that neurology, which caused all the symptoms. And then when you fuse that area where there's no more movement at all, therefore there should be no more compression on the neurology. Therefore, all the nervous symptoms, should resolve. And when you see that in many of these cases, there is no other answer that's a potential thing that could have been causing that, such as some kind of a disease or some kind of a slow progressive autoimmune condition. It's literally the instability was causing this. And I'm not going to say that if there wasn't some kind of a genetic disorder or some kind of an inflammatory condition that wasn't the cause of the ligament damage or the ligament erosion, which led to the instability. But at the end of the day, the instability is what is irritating the nervous system. And that's what causes this whole slew of symptoms that people live with, whether it's then labeled as, traumatic brain injury or mild traumatic brain injury or post-concussive syndrome or whatever. Those are all then labeled based on what the symptoms are that a person presents with, but they don't really tell you what the cause is. So when you can diagnose the instability, then you know what the actual cause is, and you can label it as C1, C2, ligament X, Y, or Z, or X, Y, or Z is the actual perpetrator, because the movement that it's supposed to resist based on the motion imaging is happening in excess. Therefore, that ligament is not preventing that excessive movement. So you can have a concise diagnosis of saying it's the right alar and accessory ligament, or it's the right transverse band of the transverse ligament causing this excessive movement, thereby causing atlantoaxial instability, causing cervicomedullary compression of the brainstem and upper spinal cord, yielding the gamut of symptoms that people may have been told are called POTS, or are called dysautonomia, or are called ME, or are called CFS, or a whole slew of other potential fibromyalgia. All these different labels that people are given that literally describe the vast majority of the symptoms they're experiencing, but don't really tell them what's wrong. And so if you don't really know what's wrong, it's really hard to do something about it, other than taking something that hopefully will aid in masking your brain's ability to perceive those symptoms. And that, in my mind, is not making the situation better. It's making the situation, hopefully at best, less perceivable.
Correct. It's not going to the root. I think that's a huge problem in what's happening. The root cause isn't determined, but it's just the symptoms are suppressed. They're pushed down, which basically prevents correct diagnosis. And so it's a cycle that continues and results in a lifelong, suffering experience. So that was huge, Doctor, what you talked about in terms of diagnosis, because I think the typical X-ray that is done of the cervical spine or the brain, of the skull, I mean, it's not intended to look at the C1, C2, right? Am I correct?
You're talking about the regular X-ray or MRI?
Regular X-ray, it's not. It doesn't tell you a lot about what's going on at the C1, C2. Even the MRI and the X-rays, conventionally how they're done, it's the C2 and lower, C2 to lower.
Yeah, that's definitely with MRI and CT. X-ray, X-ray should show that, because they're supposed to have a side view, a front to back view, and then a front to back view with the mouth open, which then exposes C1 and C2. And I've unfortunately, to my dismay, seen a lot lately where the open mouth is actually omitted. And that should be the absolute standard, should be the side view, the front view, and then the front view with the mouth open, right? So you can see C1 and C2. And so technically the X-ray is when done with those three views, so front, side, and front with the mouth open, at least shows the C1, C2 much better than a lot of MRIs do. So when you're dealing with an MRI or a CT scan, the side view shows literally from mid-skull to the first few segments in the mid-back, so it definitely gets the whole neck. But then when they do the actual top-down slicing, they'll usually start at C2, and they'll mention that oftentimes in the report, went from C2 to T1 or C2 to T2. And what they're doing is they're omitting C1 and the skull. And that's really the junction point where a lot of these problems occur. And so you see them only in one plane of view. The second plane of view, they actually start below that area and they're slicing downward, and they still call it the neck, even though they're excluding the upper 30% of the neck. And then the third plane of view in MRI is front to back slicing. So we have side to side, top down, and then front to back. And so the side to side is good because they get a lot more than even just the neck. The top down, they omit the upper part of the neck, and the front to back, they don't even do oftentimes unless it's specifically requested. And so I think, in requesting imaging as a physician, physicians should try to get a little bit more, especially if they've listened to this or heard this, get a little bit more proactive and not just asking for a cervical spine MRI or a cervical spine CT, but actually ordering on the requisition cervical spine MRI, and then requesting specifically axials to be done from, occiput, which is the skull, down to T1, and then also include coronals showing occiput to T1, so that they're actually getting all three planes of view, which helps you better triangulate all the tissues. But also it forces the MRI facility to actually include the entire cervical spine, because the reason that the lower or the upper part of the cervical spine is often omitted on the top down view is that there are no discs in the upper third of the cervical spine. And the whole purpose of MRIs of the neck specifically has historically been to look at, does this person have any bulged or herniated discs, which would potentially qualify them for neurosurgical intervention to remove the disc and take the pressure off the spinal cord or off of an exiting nerve. And so because there are no discs in the upper 30% of the cervical spine, then by default, what's the point of scanning that if you're looking for disc pathology? And so when the doctor, any doctor listening to this kind of thinks around it and goes, I'm about to, refer a patient for an MRI of their neck because they're having headaches, dizziness, nausea, neck pain, potentially arm pain, blurry vision, ringing in their ears, all these concussive-like symptoms, plus also neck-related symptoms, they should say, okay, I'm going to ask for a standard cervical spine MRI, but I'm going to ask them, in addition, to make sure to include the upper part of the neck as well, up to the skull, and then do all three planes. So we want X, Y, Z, and we want the entire neck on all three of those sequences, or all three of those the planes of view.
That is very critical information, especially for the MRI. When you're doing the MRI, again, making sure that this, you're going from the base of the skull, from the occiput to the you said T2, right? T2.
Yeah, as long as they get the full cervical spine.
Yeah. Just don't go from C2 to lower. Just make sure that junction is captured.
Yeah. So the skull they refer to as C0 or the occiput. So they go from C0 all the way down to T1 or T2, whatever they go to, as long as they include C0, C1, C2, and then all the other rest of the cervical spine. Then at least you're getting the full picture. And I think it's more diagnostic than the way it's generally, historically been done up until now.
Right, and also you mentioned going from getting the front views as well, which are often missed, right?
Yes. So you have sagittal, which is side to side, axial, which is top down, and then coronal, which is front to back. Those are the three cardinal planes in anatomy. So side to side, top down, and front to back. So you have X, Y, Z coordinates.
Right.
And that's how things in the body should be assessed, and not just, we're a three-dimensional object. And if you have the ability by way of MRI or CT scan to look at this, three-dimensional entity in 3 dimensions, I think it would be logical to me to do that and not omit one of the planes for whatever reason. I don't even know what the reasoning is, but it shouldn't be omitted. It should be X, Y, Z, and X-rays are 2-dimensional, and so the best you can get is front to back, side to side, and depending on what tissue you're looking at, you can do diagonal or 45-degree views to accentuate other anatomy, but MRI CT is far more capable of looking 3-dimensionally at a human body. And again, these are all static imaging sequences, so if you're not picking up anything, that doesn't mean there's nothing there. It just means the static anatomy in neutral anatomic position is sufficient. And so when you get that, it doesn't mean that the story's over and imaging is completed. If you're not seeing anything there that tips you off as to what the potential problem could be, and the person has the symptoms that qualify, so headaches, dizziness, nausea, potentially temperature control problems, heart palpitations, problems being upright sometimes, weakness, numbness, tingling, visual changes, sensitivity to light, sensitivity to sound, fullness in their ears, forgetfulness. So all these things, then the doctor should say, okay, we've done this static, neutral anatomy, imaging, and it's not showing anything, or they're telling us it's unremarkable. How should we challenge these tissues to go to the next step and do imaging that could potentially show us the needle in a haystack? And so this is where doctors need to, and patients need to be more proactive too, after hopefully listening to this. But doctors need to be more proactive and say, okay, tell me exactly when you have the dizziness flare up. For example, when you're driving your car and you shoulder check for 7 seconds and you come back, do you feel lightheaded or dizzy either while you're holding your head there looking backwards or upon return? So if the person says, yeah, I feel lightheaded for about 10 seconds every time after I come back from turning my head left and coming back to neutral, I have this refractory period before my brain settles down and I can see clear again. That should be a tip off that you need to stress those positions with some kind of imaging to see if something happens. And so outside of sending people for continuous MRIs or CT scans, especially CT scans, since it's a high dosage of radiation, outside of sending people for CT scans and MRIs, this is where the motion X-ray or fluoroscopy comes in very handy, because its job, its ultimate job, and the only thing that it is used for is to assess movement in all three planes. So front to back, side to side, and then rotation. So when you're looking at those movements under real-time fluoroscopy or real-time motion X-ray, so the person's actually doing the moving, the machine is actually allowing the motion to happen and actually picking up and seeing what's happening. So it's not like a panoramic X-ray at a dentist where you're stationary and the thing rolls around you. You're actually moving around while this thing is imaging. And so once that's done, then you can actually see functional abnormalities in a person's movement between, bone 1 in the neck and bone 2 and bone 3, bone 3 and bone 4, etc., all the way through the neck, in front to back movement, in side to side movement, and in rotational movement. And then by seeing these abnormalities, you can say, okay, this is moving too much. And because it's moving too much, the spot is within that area that's moving too much is either, for example, the upper cervical spinal cord or the lower brainstem or the medulla oblongata, which is the lower brainstem. And this person is telling me that they're having balance issues, hoarseness of the voice, heart palpitations, temperature control issues, digestive issues, visual changes, runny nose, sinus stuff. And you can say, okay, do the cranial nerves exiting off of that part of the brainstem have any involvement in any of those functions that this person is telling me about? And so, like you and I talked about last time, if you just Google what the vagus nerve does, you'll probably fall, faint based on finding out how much involvement it has in the body as a whole for background functioning. And so, any of these, organs that start to, ramp up their activity when they shouldn't be, or ramp down their activity when they shouldn't be, it's very plausible that something happening within the vagus nerve is causing that. And the vagus nerve is but one example of one cranial nerve. And fortunately for this discussion, it is the major cranial nerve that has the farthest outreach in the human body for background function and existence.
Right, makes sense. So anybody who has access to a dynamic digital motion X-ray, go get it done. If you don't have access, make sure that you listen to this video again, look at exactly what Dr. Blaskovich mentioned in terms of making sure you get that open mouth X-ray, making sure you get the C0 to lower scans, making sure you get the sagittal, if I'm correct, sagittal, right? Sagittal view.
Sagittal side to side, coronals front to back.
Sagittal and the coronal views, make sure you get these done. So like, even if you don't have access to a digital motion X-ray, there's at least something that you give the doctor to work with, right?
Yeah, and if it's too confusing, whether for doctors or even for patients, they can always feel free to reach out to me and ask for guidance on what to request and how to request it, especially for the doctors, because they're the ones that actually have to fill out those forms. I'm happy to assist whenever I can. And if there's, as far as the motion X-ray or the fluoroscopy, video fluoroscopy, there's a website, motionxray.ca. So it's called motionxray.ca for Canada. And so there's an example on the homepage, I believe, of me performing an actual motion x-ray on a real patient who's allowed this to be published. And at least it'll give an impression on what the intent of this imaging is, because there's an explanation in there of how it's done, and then what we're looking for while we're assessing the actual imaging.
Right. So perfect. What we'll do is I'll attach Dr. Blaskovich's email, phone numbers to his office. So if any patients, any doctors who are, have some questions can reach out to him, because he's been through this. He understands the pain, and
Yeah, I'm happy to help. No problem.